And then we're all very, very glad to have you with us to start our first ever book club. We're excited about the book we're going to review. We're even more excited to have you guys here discuss it with us. So we want this book club to be conversational in nature. We don't envision this being a us talk at you sort of a thing. So please feel free to chime in either with your audio or through typing in the chat, anything that comes to mind as we're talking about different things. And then I'll leave the second part of my spiel out as well too, since we're all kind of friends and know each other here. So with that being said, before we get started into book club, I think we all kind of have a general idea of who each other is, but if we could just go through and do a brief round of introductions, just who we are and who we're with. So I think I know everybody here. My name is Matt Tebow with KBGH.
And I'm Justin Moore, a medical director with the business group.
Hi, I'm Sherry Pate. I'm the HR director over benefits at Intrust Bank.
I'm Brandon Ullman. I'm a physician and business owner at Antioch Med.
Bob McCollins, peer to Matt and Dr. Moore and Shelley, involved with the Employers Advanced Cooperative on Healthcare. We're a sister coalition based in Fort Smith, Arkansas, but also partnering with KBGH on a couple initiatives, a STAR Captive and ECRX pharmacy program.
Great, thanks everybody. So you should have received just some kind of prompt questions that we'll loosely go through this book club, just to kind of get the conversation started. We're gonna each take turns leading sessions, and we're lucky to have Dr. Moore lead this session with us, this first session. So I'll turn it over to him to get us kicked off.
Sure. Well, you know, coming into a discussion like this as a physician is interesting because at least so far, this book really focuses mostly on kind of transactional stuff outside of the exam room. But I have to go into a book like this confronting the fact that I am likely part of the problem here, right? My read of the literature is that the three biggest sources of excess medical spending in the United States are: number one, pharmaceuticals; number two, physician and nurse salaries; and number three, administrative complexity. And probably all of us are part of the problem in terms of administrative complexity, with the exception of maybe Dr. Allman, who runs a pretty clean operation. But so that's the perspective that I took going into this, and I don't think it disappointed necessarily in that way. And at the same time, I think this book really, I mean, in spite of the fact that the guys that wrote it are trying to sell something, you know, they're in the business of Health Rosetta. In spite of that, I think some of these problems can be solved without necessarily thinking of, you know, something to sell. The problems are so pervasive that they're maybe best thought of as systemic. There are little niches that each of us can carve out and try to help things, but it's interesting that the two forewords to the book kind of went through 7 problems, and then Dave Chase himself listed his 2 biggest problems, and none of them overlap, right? They all name different things. So there is no shortage of problems to try to confront here. So I'll stop rambling there and just see what other people thought, what points stood out to other folks.
The last thing you said, Dr. Moore, I kind of look at it, you have to pick your poison, you know, or pick your priority, you know, what's most important to you, because there's no way you can solve this by eating the elephant in one bite. You gotta prioritize and figure out, do we do the low-hanging fruit approach and kind of baby step, or do we, you know, rip the Band-Aid off and go after the big stuff? And that really comes down to consideration as to what, you know, what's the priority for the employer and you know, their decision making. So, and education. It is complex, but we need to do a better, we as everybody. So we're all at fault. We're all guilty. But, you know, a better job of education to respectfully Jack and Jill lunch bucket, that they can understand this is I think, something that easily could be done.
Now, there were a couple of things that struck me, and it started in the forward, and it carried on through the chapters that I read for this session. You know, sitting in the employer seat, it was a good reminder that not all parties who are, you know, here to help us, whether it's your TPA or your fully insured partner or your broker, they all are definitely financially motivated. And I know that I've been in this business long enough to know it, but I guess I probably was a little bit naive by choice to really the full implications and the impact that has on our company, on our employees, on this whole situation. And the other thing that struck me as well is that you know, to echo Bob's comments, education and helping shift that mindset from this being the only option we have, I think is a challenging one, but definitely one that I think is worth trying to figure out how to pursue.
Yeah, I'll one thing I'm curious about is on the education front, or maybe it overlaps with transparency. This book was written in 2017, and just in the last maybe 12 to 18 months, we've had 3 big rules come down, either by executive order or through omnibus legislation or other, around broker transparency and surprise billing and hospital transparency. None of them, or they don't all take effect right now. Some of them wait until December of January upcoming. But do you guys see those changing your relationship with any of those organizations, either your broker or the hospital or anyone else?
Honestly, I think it will be difficult to make rush decisions once we have the additional information in front of us. We already, through our broker, at least on our welfare plans, know what commissions they receive. I'd probably have to dig pretty deeply to see if we have that information on the health plan, which is of course the biggest spend. But I think it would take a lot of due diligence to generate the desire to move. Moving a health plan or changing brokers it can kind of be a lot more work than you would anticipate. Not that I don't think it's necessary if you find evidence that compels you to do so, but it should be done thoughtfully, I think.
Yeah, I not speaking from experience working in the field like you, Sherry, but just kind of looking from the outside in, I imagine that's quite a heavy lift. And one of the things that I think, because brokers, pharmaceutical PBMs, pharmaceutical manufacturers, they often come under fire quite a bit. But to be fair, there's a lot of value that those entities provide. Like an employer could not, I mean, it may be technically possible, but it'd be very, very difficult to navigate the healthcare ecosystem without a broker. So you absolutely need a broker. But one of the things that stuck out to me in reading just this opening section when they talk about conflicts of interest and how if this same level of conflict of interest existed anywhere in any of the other fields that we work in, if you went to a financial advisor and you found out that they were getting paid by a certain investment company, that investment person could lose their license or go to jail, or and some of those same levels of accountability don't exist in healthcare for whatever reason. And addressing this, because we like the people that we work with, we like the brokers that we know, we like all the people that we know that work at the PBMs or the pharmaceutical companies. And so we don't want to have a confrontational conversation with them, but sometimes it's those more difficult conversations, just kind of about the facts and about what the ultimate goals of you, the client, are, whoever the client is for those different organizations. That's really seems to be the sticking point in American healthcare.
Now, the brokers get beat up pretty bad in this first section of the book. I mean, I think for the record, I think some of them deserve it, but yeah, you're right. I mean, the conflicts of interest go all the way to the bone in medicine. You know, there is at least one primary care practice in Wichita that makes 2/3 of its revenue by owning its own imaging machines. And we have very good evidence in the medical literature that says that if you own your own MRI, it's getting used, right? It's not going to lay there and, you know, and not work. And so the very relationship between the physician and the patient is even tangled up in a lot of cases with conflicts of interest. So.
Yeah, I've heard, Dr. Moore, I've heard you use the phrase the banality of evil before, right? And that, and that's just like very evident in the healthcare field.
That was Hannah Arendt's. I stole it from her. Yeah.
Yeah. But like, yeah, it's another quote I like is like every system is designed to achieve the outcomes it's achieving. And like the misaligned incentives in healthcare are leading to these outcomes. Nobody likes them, but if we keep the same incentives, we're going to keep getting the same outcomes. And that applies to physician, to broker, to TPA, to PBM, to everybody along the chain. So.
Yeah. And I just want to take a moment to welcome Kirsten. Thanks for joining us, Kirsten.
Sure, I apologize I'm late. I got caught on another one.
That's okay. Would it help to do since there's just a few of us in here, would it help to do just a brief round of introductions, Kirsten, so we can all kind of know who's here?
Sure.
Well, I'm Matt Tebow. I'm with the Kansas Business Group on Health.
And I'm Justin Moore, the medical director here at the Kansas Business Group on Health.
Hi, I'm Sherry with Intrust Bank Human Resources. I'm the director over benefits.
I'm Brandon Allman. I'm a physician at Antioch Med, direct primary care clinic and business owner.
Go ahead, Kirsten.
Sure. Kirsten Camp. I work for Textron Aviation. I'm a nurse practitioner by trade. Worked the first 15 years of my career there in our on-site occupational clinic, and now sit on the HR side, primarily doing all things disability management.
Good. Bob McCollins, Employers Advanced Cooperative on Healthcare. We're a sister coalition out of Arkansas to Kansas Business Group on Health, and also a business partner of some of their initiatives.
Great. Thanks for the introduction. Sorry to interrupt.
No, that's okay, Kirsten. So just to catch you up on where we were kind of talking about how conflicts of interest are kind of pervasive in medicine, all the way from the bedside, you know, where if you go to the cardiologist and they have the choice of prescribing, you know, cardiac rehab or taking you to the cath lab, every incentive is for them to take you to the cath lab, right? And that goes all the way through our insurance and benefits purchasing, where brokers are mostly incentivized to get us to spend more money. PBMs are incentivized to offer big rebates to get medicines moved to the top of the formulary, et cetera. There's just no one's hands are clean in medicine, and we were kind of tiptoeing into that discussion.
Thank you.
Sherry, I've got a question for you, and you can think about it and answer it later. And it's not fair, probably, that you're maybe the only HR person represented here today, but you talk about change, and that is an obstacle. That's a heavy lift to change from one health plan to a different health plan. So my question is, what's the delta that would compel you to seriously consider moving from carrier A to carrier B, or this self-funded plan to this self-funded option? Is it 5%, 10%, 15%? I mean, and from an HR perspective, there's a lot of work. What's that percentage that you would have to be confident that you're going to save to really take that step to move?
Off the top of my head, I think it would have to be greater than 10% easily, okay, simply because of the navigation involved. And, you know, when I think of the last time we made a transition, it was probably the smoothest experience that we've had. And it wasn't necessarily cost driven at that time, it was quality driven.
Okay.
So I think there's got to be a balance there. We were partnered with a health plan carrier for probably 8 months. We had made the jump at that point, and we're fully, or no, I'm sorry, we were self-insured. And again, at that 8 month point, we knew we had gotten ourselves into a disaster in terms of quality. And so we marketed the plan again the following year. So quality probably as important to cost, but 10% or more at this point.
Okay, thank you. Thanks. I was just curious.
I'm glad you mentioned quality, Sherry, because one of the initial things that comes up in the foreword to the book is that there's really not much accountability on the part of health systems or physicians. Now, again, this book's a few years old, and I think things are slowly changing to put more emphasis on quality. But I'm curious how many folks out there really know the quality of care they're delivering if they're a doc, nurse, whoever, or B, know the quality of care their employees are receiving if they're a purchaser. Do Sherry, you or Kirsten, do either of you feel comfortable talking about how or if you get quality data back from folks?
I would say we really don't have any idea, unfortunately, about the level of quality of care. I get data on claims activity and cost, but not around quality.
Yeah, I don't think that's unusual. But.
I would agree. And I would say, every health plan will tell you that their network doctors are selected based upon quality and cost measures. I don't know that as companies, we really have a great way to verify what data they're using to put behind that. And certainly I don't feel like the consumers understand that either, nor do they trust it, right? I think there's a bit of a level of distrust by a consumer if an insurance company is saying, well, you should use this provider or this provider. Of course, the first thing they think of is, oh, they're just trying to save money, right? So I think when that is the only bit of quality information that we get, and it's so limited, I think that does not help our case with trying to drive consumers to the right point of care at the right time.
Yeah, I agree wholeheartedly. And, something else that the book speaks to, and this is where we in HR kind of get a little bit sideways with our executive management team is, we know there's data out there through organizations like Leapfrog that really could help us better understand quality providers and primarily in terms of hospitals. But to think about only offering the choice for employees in Wichita to go to one hospital versus the other options that are there, there has not been a demonstrated appetite for it. And so there's, another challenge that we would have to overcome is helping make that connection at the executive level.
Do you mean the executives themselves just aren't that, when you say limited appetite, the executives themselves just aren't that interested, or the patients, or?
No, we love our employees, and we don't like to do anything that really gives the appearance of rocking the boat too much, which can at times make me feel as though we're a little stagnated. And, we've struggled to figure out what is the right data set to put in front of them to help move us in a more forward-thinking direction.
Yeah, I think that is a really interesting, there's an interesting intersection between that and how you talked about employee kind of happiness and what people expect when they go to the doctor. Because back when I was in full-time practice, there were a lot of people that came in that I knew within 2 minutes of walking into the room that the best thing I could do was leave them alone, right? Not do any testing and not offer any therapy. But that is not why people come to see the endocrinologist, right? They want something done. And so it's very hard to offer appropriate minimalist therapy and not have people go online and give you a 1 out of 4 star rating on some website. And so this might be a good place for Dr. Allman to talk about if there's a way he handles that, considering I think just his business model operates with a lot more kind of shared decision making around what you're going to spend money on. Is that fair to say, Dr. Allman?
I think the slight advantage we have doing direct care is we have time, but I still think the approach of a lot of patients is the vending machine approach. I know what I need going into the room, and you can spend the time explaining that, and 2/3 of people are on board with that. We call this itis season. So we have the itises coming in all the time. So sinusitis, bronchitis, and discussing accurate care, we lose patients over that. And it's hard to know. I think Kansas ranks like 49th or 50th in antibiotic prescribing. Do you know that data better than me?
I do not know that data.
Yeah, I think we're in the bottom. I think we're in the bottom 5 of appropriateness of antibiotic usage, and so that's where the patient expectation and the physician quality differ a lot. But I think even in the bigger stuff, I think quality is even hard to know. So in a former life, I was in a graduate program, trying to study quality. And even when you looked at, the 10 biggest health systems taking care of preterm babies, the quality difference was all over the board. And so it's just a hard thing to measure from the outside. And it's a hard thing to measure even when you're in the field as well. So I don't know if I answered your question, but it's difficult.
Yeah, maybe it comes back to Bob's point about education. Maybe it's just constantly rolling the boulder uphill to tell people that in a lot of cases the best thing your doctor can do for you is nothing.
I see things being sold to businesses that are like, call this person and they'll tell you who the quality provider is in town. Is that being included in the health plans that the HR people are seeing?
Now, we've had a couple of opportunities to look at like demos, but I think there's enough skepticism around what really determines quality that we've just not found what we think is a good fit.
Well, here is the other issue that I see, being that I've been on both sides of the fence in my current role. One of the things that I see quite often is you can tell them who the best of the best is, but if they go to their trusted family provider and their provider tells them, no, it's Dr. A, B, or C over here, and maybe they have the worst quality in town, but they're affiliated with the same group or network, we see that all the time, right? They're going to follow the advice of their provider. You can educate them till you're blue in the face. You could probably show them all the data in the world, but unless we get the providers in town to get on board with the quality pieces too, I think it will continue to be an uphill battle.
In my mind, the quality conversation almost is bimodal, where on one end you have very, very basic care that needs to be done well, like getting people's blood pressure controlled, getting them immunizations, all the kind of foundational stuff. And then there's this big expanse in the middle that's sort of medium intensity care, like, I don't know, maybe routine joint replacements or something. But then at the far end, you have the astonishingly expensive stuff like spine surgeries, bariatric surgery, unusual chemotherapeutic regimens and that kind of thing. And where I see the most movement, speaking nationally here, seems to be on that far end, where if somebody's going to get spine surgery, we're sending them to Barrow, and that's the only place they can get it. We will not pay for this locally. Is that a movement that am I over-interpreting that from anyone?
No, I think we're seeing a push towards center of excellences.
Yeah.
for certain conditions. To your point, the very expensive ones. I don't know that we've been doing it long enough to get a good feel on whether or not it's successful at this point. But I agree. I think there's a shift to that, particularly with spine, joint replacement, bariatric. We see it, to your point. It's some of those much more expensive type surgical interventions.
And this made me think about when we talked about quality, and Sherry, before you even mentioned it, I was thinking about how generous interest is, being a former employee, and then my wife works there now, how generous interest is to employees benefits wise, and how it truly shows that you care about your employees. And then how that makes it difficult sometimes to make the changes that you might think would, whether it's quality wise, you mentioned the hospitals can only, would kind of cause some waves in the ocean to only refer or cover one hospital. And it makes me think about this, help me out here if this isn't the right bias, but kind of the loss aversion bias about how we're more afraid of losing something than what we could potentially gain with the change. And I wonder, as I'm reading, the reason I bring this up is I look at on page 20 where he talks about, in this point of the book, he's talking about how much we waste on musculoskeletal surgeries and when maybe physical therapy would do, but we get unnecessary treatments done in there, and how that and other sources of healthcare waste contribute to, almost $1 trillion or $750 billion every year in wasted healthcare. And then when he talks about the things that could be paid for if we as a country didn't waste that money on healthcare, sending every 17 or 18-year-old to four-year university, funding the Department of Defense for a year, and a couple of other just really extravagant things that we could fund just with the waste in American healthcare. And so I'm curious to the HR people, kind of a twist on Bob's question of what would be the expected benefit that you would hope to get in return for the disruption that would be caused within your employees. Is there a certain threshold of employee disruption that you consider?
I don't know. That's a really good and a really tough question. I think if we were really able to get the population that we cover on the health plan to understand that more isn't necessarily better, and to really help them understand sometimes no treatment is the best treatment. And I think there's a sense of impatience that people have. I don't feel good today. I want to feel better tomorrow. And so the best way to do that is to give me what I want, which is a prescription. Or instead of doing physical therapy because I've got, whatever going on musculoskeletal wise, I'd rather have a surgery than play it out. So I think, again, it's that education and that complete mind shift that if you could get there and help people really understand that they need to seek the value in the care they're receiving, to me, that would be an incredibly worthwhile endeavor. I don't begin to know how to start, even, quite honestly.
Yeah.
I think until our providers are rewarded for education and not just action, right? We can get a different message in front of people consistently. I think that's a big ship to turn, right? We are an immediate resolution society for that. Call me for this, we'll fix you tomorrow, right? I mean, and until we get out of that overall messaging and mindset, we start rewarding providers for taking the time to educate and do the conservative care and employees, I'm sorry, I get, stuck in that, but get our patients kind of to that level of understanding. I think we're going to continue to struggle with that. I mean, maybe some of the other providers have a different opinion, but even on the occupational side, we see it, right? And 99% of what we see is musculoskeletal, and we'll do just fine with a little bit of rest and TLC, right? But everybody wants everything fixed right now. Even if it took them 2 years to get to the point they're at, they want it fixed right now. And that's a really, really difficult conversation to have with them. To Dr. Allman's point, it's very difficult to have that conversation of the best thing we can do for you is to do nothing and let your body take care of itself. But wow, that's a systemic problem that has to be fixed.
I'm not hopeless about it though. You know, if you go back in time, I don't know, 30 years, not many people had a very sophisticated understanding of cholesterol, right? And now you could almost pick a random person off the street and they would know that, you know, having a high LDL cholesterol is a bad thing and a low HDL might be a bad thing. So these things do penetrate the general public from time to time. Like I said, maybe it's just this Sisyphean task of continuing to reinforce. I mean, people ought to just be able to look at their neighbor. You know, how many people do you know that have had big spine surgeries that were fixed? I mean, it's like none, right?
None.
So
Yeah.
people ought to be able to just look around and take a semi-jaded view and see that maybe some of these things don't work as well as advertised. Yeah, but it's hard. Yeah, there's no easy solution in the short term, unfortunately.
And another one of the things that stuck out to me kind of in this same realm of what we're talking about in terms of unnecessary wasted healthcare that we as America spend, as far as I know, Dr. Moore, correct me here, but you know, we spend far more than any other country, but I think our waste is far more than any other country as well. And without realizing the impact that has on all facets of kind of American financials, but even directly to the employee, looking at the graph on page 15, where he talks about how with more and more of the employee compensation having to go to cover medical expenses, employees actually are getting raises. They just don't actually see them in their paycheck because the cost of providing insurance keeps going up and up. And so they actually are being compensated more, but they don't feel it. And the reason they're not feeling it is because of all this waste in the American healthcare system, which is really the premise of this whole book is, you know, that's what's choking out the middle class. So that was interesting to me.
Yeah, if anybody read our blog post from last week, you may think that we're trying to take people back to this sort of 90s HMO gatekeeper model of care, and maybe we are, but it seems like the first step in avoiding medical waste is just somehow nudging or forcing people to center their care around a primary care doctor. If you saw the study that we blogged about, it was that in Medicare, in a big Medicare data set, about 2/3 of the non-cost-effective care that was delivered to any given patient was delivered by a physician that had no relationship to the patient's primary care provider. The patient had presumably seen a billboard or seen an ad or something and gone somewhere and gotten one of these 31 unnecessary services that the investigators outlined. And so had they been forced to go through a primary care physician to get those, you would have to think, you know, 2/3 of those would have been eliminated. I don't know. I don't want to be too heavy-handed, but it does seem that we need to recenter primary care as the place people are getting most of their advice from.
I'm biased in that, but I agree.
Yeah. No, I happen to be married to a primary care provider, so my hands aren't clean here either. But yeah.
What's that conflict of interest thing you were talking about?
Yeah, no, I know. I hear you.
Just kidding.
Well, to that point then, Dr. Moore, you know, later on in the, I think it was the 3rd or 4th chapter, it talked about how there's an idea that millennials might be able to help navigate us towards really improving healthcare delivery. And, you know, primary care physicians is something that they really don't seem to latch onto. And I work with a number of millennials here in our department. And I mean, number one, if they actually go to the doctor, it's someone that they either literally look up online or they use Teledoc. There's not that relationship building. So how do we help point them in that direction?
Yeah, I don't have the answer. I actually have it in my notes here that I said, is anyone else skeptical of the millennials will save us chapter? It's because I'm not a millennial. Yeah, no, I agree. I think the data clear, and maybe it's data that's come out since 2017, who knows, but the data clearly indicate that the younger that you are, the less you value a relationship with a primary care provider. Younger people value access, just like they value access to transportation through Uber or Lyft or something, but they don't value that ownership of a personal physician that somebody, say my parents' age, does. So, the thing that we've pushed through the business group is we've tried to nudge companies away from offering things like Teledoc and toward trying to facilitate the local primary care doctors being able to do telemedicine themselves, for instance. If you make the local practitioners more available somehow, make it easier for them to do those things, maybe it threads that needle. But beyond that, I'd be curious what other people have to say.
I think when primary care is viewed as only transactional, like, I have one problem, I get to talk about one problem, and then I'm going to get something at the end. That's very easy to interrupt, right? I can do that with an app and a smartphone, and I can do it in 5 minutes. So the physical doctor is then not valuable. But I think, like, you see the wellness industry is very successful at capturing millennials. But if you take an evidence based around them being, physically well, emotionally well, all of those things, depression is something that Kansas Business Group on Health has talked about a lot. I think if the primary care becomes the place where you're doing good, yes, just physical medicine, but caring about these other things, I think you may capture millennials more than just, hey, I'm there for my one transaction.
And so that requires major payment reform, right? I mean,
yep.
Yeah.
Well, not for us, but
well, not for you. You're already on the other side of the payment reform, but for the rest of us, yeah.
Sherry and Kirsten, could you just briefly share what type of a benefit plan you all have for your employees and work families? Is it an HSA high deductible, kind of program, or multiple options?
Yeah, we offer
Sure.
3 different health plan options right now. We have 2 PPOs with varying deductibles, and then we do offer a high deductible plan with an HSA. And we have, for a number of years now, provided employer contributions into the HSA accounts.
And with the 2 PPOs, what is the primary care physician copay in those PPO offerings?
I want to say one is 25. The premium plan is 25, and I think the base plan is 40.
Okay, and then of the 3 plans you offer, where's the most of the enrollment of your employees?
High deductible.
In the HSA plan, which has no primary care physician copay.
Correct.
Yeah. Until you meet the deductible.
Right.
Okay. All right.
Right, but we provide $850 a year to everyone in the plan.
Okay.
To help offset that expense.
Okay. All right. Great. Kirsten, how about you?
Yeah, so I'm going to qualify this with I am not a benefit specialist. That is not my area of expertise. So I can only tell you the basics. The other qualification I'm going to do is we don't control our benefits locally. So we have a parent company right out of Providence, Rhode Island. And so they control the benefits plans for all of the businesses that are owned by Textron Inc. Gotcha. So that's the other piece. We have no control at the local level.
Okay.
We offer a deductible HSA plan, and there is an employer contribution into that. And then this year they added a no deductible plan through Bind, I think is the name of the company. And I'm sorry, I don't know a whole lot about it. Yeah.
Okay.
I know that the union, right, was really pushing for something other than the high deductible HSA, and this was the solution that was offered.
Got it. Okay, great. Thank you all.
Sure.
Sherry, I don't mean to pick on you, but I'm curious what your reaction to the part in the book where he talks about, or whoever it was writing that section about kind of making the resources or the integration points or whatever you want to call them with the healthcare system free or low cost, whether that's, so talking about the network not excluding one hospital, but if you more incentivized or covered the copay completely for one hospital provider or the other. What's your reaction to that? Because I imagine there's maybe some heartache or some heartburn about thinking about, letting people go somewhere completely for free. But if it's higher quality, does that in your mind kind of ease those concerns, or is that something that you all have considered at interest? I'm just kind of curious what appetite there is generally among employers for strategies such as those.
Well, I'm intrigued by that. I don't know that I know enough about it. Obviously, you would have to have the focus being on quality and outcomes in order to be able to deliver something to like what they described. And if I remember, that model offered a significant reduction in overall cost to the health plan. So to me, we would have to understand what is that trade-off in offering solutions like that, whether it's on-site, if it's an on-site clinic, on-site wellness. And we have explored on-site or near-site clinics, and again, just haven't really found the right fit for us. And I think the challenge that we have now is we've spent so many years trying to help people be better consumers, and quite frankly, through the contribution that to unwind that, while not impossible, would really require a lot of thought and care and consideration to how that message is delivered.
Yeah, a big challenge locally in sort of assigning one hospital system this high quality kind of designation is that our two major local hospital systems have kind of self-segregated themselves out into different things, right? So, and I don't have the data in front of me, and so don't take this as any endorsement of one or the other, but the HCA Wesley system has very much kind of embraced the we take care of mothers and children part of things, and so it may well be possible that their outcomes are better. I don't know. Whereas Via Christi has more embraced, or Ascension Via Christi has more embraced kind of cancer care and later life stuff. So it's entirely possible that their outcomes are better in that. So to say that one hospital system sort of gets the gold stamp for all of your employees gets really complicated depending on what their care is for. And we say that, and Matt can jump in here too. We say that as a leapfrog region. I mean, we ought to know this as well as anyone, and I don't think we do.
Yeah, I agree. Some of the leapfrog data would show that both in their quality scores and in the award that KSARC won, Kansas Surgery and Recovery Center. Some providers and facilities do just outperform others, and they could be within one department or physician or provider within Wesley may be better than another one at Wesley. So that's a good point. And not to think of excluding entire systems or hospitals, but trying to identify what providers within those systems would be the best to refer to.
So we have 10 minutes left, and I intend to stay under time. So I'm just curious if there's anything that has stood out to anyone in terms of what they expect or want out of the rest of the book, or if there's any change that they see themselves making now. I think from my perspective, the book has just really highlighted the fact that there has been some really big change since the writing of this book, especially around transparency and around the relationship to brokers and around surprise billing. And we as the business group just need to make sure that we get that information out to our members. Anyone else have, and I don't mean to put anyone on the spot, but any observations from anyone else?
Just kind of wonder, the question for the company is the kind of audacious claim of this book is like, doesn't it say something about for half the price? And we were talking about 10%. Like, do you feel like over 10% is even feasible? Like, does the claim of the book, do you think a compelling case can even be made for that claim?
You know, I don't know. I mean, for us, that's, 10% is $500,000 of our spend just on the plan side. I think, again, to make this sell here, we're a conservative bank. We've got a population that, our average tenure is almost 12 years. We've got people who've been here for a long time. And so it would have to be a combination of the financial shift and the buy-in and support. And that's, going back to Dr. Moore's original question, I think that's what I'm hoping to gain out of this is what are some real practical things that we could move forward with, because, not only do we have a C-suite that doesn't like to rock the boat in terms of what employees want, we've also got multiple locations to deal with. And so while we could probably do things in Wichita that would get us there, I struggle with, could we carve out Wichita and do something different with them when I've got 45 other locations that we also have to balance? And the opportunities probably wouldn't be there like they would here. So, if there are smaller things that we could do to help better manage our spend, to help better steer towards employees, towards quality, I think that's probably the starting point for us versus something big right out of the chute.
That makes sense. Because you guys are in Oklahoma too, right? You're not even just in Kansas.
Yeah, we're in Oklahoma. We've got a small location in Arkansas, and the rest of our Kansas locations are spread through north central and northeastern Kansas.
You guys are all over.
And I would say we have some of the same challenges, right? We have facilities all over the country. And you couple that with the fact that we really don't have any local control over our benefits or our benefit strategy. And so for us, I think it's more of how can we get creative within our kind of control to affect what change we can and drive people to better quality, lower cost, right? And really help both the employee and the company without having that direct control over the benefits.
It is an interesting problem. Yeah. And it's never good to be interesting in that way. It's interesting
Well,
to be hard in this case.
All right. Well, I think this was a really good session, really good opening session for it. So just as a reminder, this is the first of 4, so we hope you can join us for the other 3. We did decide to record this. If that's a problem with anybody, let me know. We had a couple of the people that couldn't make it ask if there would be a recording, so I recorded it just in case. But if anybody has objection to this being shared, please let me know offline, and we're happy to respect that. So our sessions will be every other week, this same time and day. So every Tuesday, every other Tuesday through the end of March. We'll be meeting from 10 to 11, and we'll cover, there's 4 sections in the book, and we'll cover 1 section each time. Be on the lookout for an email from me. We'll send out, kind of like we did before this session, just some kind of questions to maybe consider before the session to kind of get the conversation started. So thank you again all for being here. If there's, if you want to connect with anybody offline, let me know. And I think, again, if you have problems, don't want your information to be shared, let me know. But I think anybody in this group would be happy to talk to anybody if you had questions for any one individual person. So other than that, feel free to contact me if there's anything we can do at the KBGH. And thanks again for being here. We'll hopefully see you next time.